Okay, good evening everybody. My name is Deirdre Shanley and I'm Head of Schools Division here in the Department of Education. And I'd like to welcome you all very much to our webinar specifically for school principals to engage with the Department of Public Health around COVID-19 in schools. I'm just going to start with some housekeeping arrangements for the webinar this evening. The webinar will be about 1 hour long. It is a broadcast event, and that means the question function is live. It may not be possible for us to get to answer all of the questions live this evening, but we will do our best to get through them all. Afterwards, we will take all of the questions that have been submitted and we will try and answer them later and put them up on an FAQ section for schools on the Back to School website. Just to begin, I'd like to say on behalf of the department and on behalf of Public Health, thank you very much to the team from IMS who are facilitating the platform this evening and who have also arranged the logistics for the event. I also want to thank very much Tralee Education Centre and Terry O'Sullivan, who have done all of the supporting arrangements for this event. So I thank both of those partners who have helped us organise this evening. Within the department, we have Clean O'Neill and Pierce O'Queeve, who are also supporting from the department's communication unit. Tonight we have we're very grateful to have the support from two senior public health specialists, Dr. Kevin Kelleher and Dr. Abby Collins. Both Kevin and Abby have been engaging with the Department of Education and all of the partners in education to support schools operating safely in a COVID context. In that context, we have had a lot of meetings with public health and with the education partners, and we have engaged extensively in the context of providing support and guidance to schools. A lot of that guidance has very much been informed by feedback we've received from principals who are operating on the ground and who are working together with the whole school team. So the principals and the deputy principals who are all working together with the whole school community to support the safe operation of schools. We know and understand that there is a lot of pressure on the school leadership team and that principals and deputy principals have had to work extremely hard over the last number of months to ensure that schools are operating safely. And on behalf of the Department of Education, I want to thank you all very much for the cooperation that we have experienced and your engagement and your work in terms of providing a safe environment for the children and staff who operate within schools. So at the end of this webinar this evening, there will be an opportunity for you also to provide feedback should you wish to do that, and we'd very much welcome any feedback in how we can support and reach out to you in the context of continuing to operate in partnership with yourselves and supporting schools in these very difficult times. So we're going to start with a presentation from Dr. Abby Collins, and then we're going to answer some questions with Kevin and Abby engaging on some of the questions that we get this evening and also some of the questions that have been submitted in advance. So hopefully by the end of the hour this evening, we'll have answered a lot of your questions. And as I said, we will endeavour to provide answers on FAQs subsequently. The webinar is recorded and it will be available to view subsequently for anyone who wishes to tune in at a later date. Okay, so I might hand over to Abby at this point.
Fantastic, Deirdre, thanks very much. I hope you can all hear me, and thanks very much for dialing in on a busy evening after, I'm sure, a busy day. So I'm delighted to be here along with my colleague, Dr. Kevin Kelleher, who will join me for answering questions later. But first of all, I'm going to run through just a short presentation with you, just really to outline some of the aspects from the public health approach, from the public health side, and run through some of the experiences we have to share those back with you, and some of the findings we've had and the data that we've collected over the time period since the schools have started. So hopefully that'll provide some interest for you and some starting point maybe for some of the questions. Just due to the vagaries of technology, I'm not controlling my slides, so someone is very kindly doing that for me. So just bear with the next slide, please, comments as we go through, if that's all right. Next slide, please. Great. So just to outline the objectives really for this presentation are to look at the outline of the public health approach, discuss elements of the public health risk assessment, what that means for us, to discuss a little bit about the close contacts, the testing and the tracing, and describe some of the enhanced services in place in the HSE for schools. Next slide. So just as a bit of context from the public health side, I've come to learn a lot more about the education and the organisation of the education side since the start of the academic year, and thanks to interactions with yourselves and thanks to meetings with the Department for Education, with Deirdre, particularly upskilling me and increasing my knowledge on how you work from your perspective. So I just thought I'd just share an overview of how we operate to provide a little bit of context to ourselves. So across the country, there are 8 departments of public health, and each provides public health expertise and services both locally and nationally. So in terms of the services that we work in, those are predominantly health protection services at the moment, and that's with statutory notifiable infectious diseases, of which of course COVID-19 is currently the most important one that we are dealing with at this time. We also in general advocate and contribute to health service and health service development and health service improvement and health improvement agendas in general. So we have a pretty broad domain of areas that we work in general, but as I'm sure you've appreciated, since the beginning of March, COVID has been the main show in town from a public health perspective. Each department is led by a Director of Public Health, and we are all regional medical officers of health working in the departments. And to give an idea, amongst the 8 departments, it ranges from about two to three people working at consultant and director level, up to about maybe 10 or so within the Dublin department there. So, you know, there's quite a small number of us who work across all of these areas. Next slide, please. So the public health approach really is about prevention and protection. That's what we'd rather people don't get sick. That's always our main aim, and it's maybe one of the less fancy parts of medicine from that perspective, but very important, as I'm sure and hope that you'll appreciate. So prevention and protection is particularly important for us. However, there are obviously cases that we have to get involved in, with particularly the infectious diseases cases, and with COVID-19, we are involved with potential cases of COVID-19 in certain settings, and of course, very definitely with confirmed cases of COVID-19. Next slide, please. So when we get notified of a confirmed case, the notification, just for interest, is required under law, and it comes directly to us from the laboratories. So we do get notified of all of the confirmed cases. And one of the things that we're most concerned about, particularly when we relate it to educational facilities or other workplace settings or healthcare worker establishments, etc., is the infectious time period. So when we get notified of this confirmed case, what we really want to do is find out, were those people in a setting where they could have spread the infection onto other people when they were infectious? And that means, were they there whilst they were symptomatic, but it also means, were they there 48 hours before they were symptomatic? Or if they didn't have any symptoms, so they had no symptoms at all and they might just have been tested as a close contact, for example, where were they in the 24 hours before they had their test? So if we identify them that they were in a congregate setting, as we call it, for example, a school, whilst they were infectious with COVID-19, that's when we undertake a public health risk assessment. If, however, when we are discussing with the case, we get information to suggest that they were not in any congregate setting in their infectious time period, for example, they weren't attending the school, which could easily happen if they were off as a close contact, or for example, over a bank holiday or a weekend or a half term, etc., then and no further action is required in relation to that index case with regard to the congregate setting. So there are other actions that we might undertake, but if they are not infectious within that setting and that time period, then we don't need to contact as to undertake a public health risk assessment. In the context of schools, because we know the communities are smaller and there's often information shared, we do ask parents if they are happy for us to share that information with schools, just such that you might be aware. And some are happy for that to occur, and some obviously wish to maintain their privacy, and we have to respect that if there is no need for us to contact the school directly because they were there within the infectious time period. If we need to do that, we do that anyway, and we inform them. But if we don't need to do that on the information that we're given, then we just ask them, are they happy for us to do that, such that you're aware? And if they do, then you're informed of that. Okay, next slide, please. So in terms of the public health risk assessment, this is a routine part of public health work. We've been doing it for years in many different contexts, in many different settings, and with regard to many different factors and many different infectious diseases. And it really enables the most accurate and effective determination of the likely health impacts of a range of possible interventions. So it's really about getting maximum information for the unique components for that setting, for that disease, etc., and then thinking about what are the best solutions for that, what are the best measures for us to put in place for that. So it's a tried and tested methodology internationally for public health people. And in the context of schools, there are three components to the public health risk assessment. There's the schools component, and for many of you, you might well have been contacted by departments of public health to undertake a risk assessment. There is also the case component, where we ring up the case and we get some information. And then because we work across our population, there is also a community component. So the knowledge that we have about that small community is also important and can affect how we might proceed forward. Next slide, please. So in terms of the public health risk assessment, what is it? Well, I've just done a quick small screenshot of the top of it. It's a form, basically. It's a 8-9 page form with lots of questions on. For the schools component, a separate form there for the case component, and then we put relevant components for the community on that form as well. So we have an aggregate body of information available to us about all of those three components. And as principals, you'll be aware of what you have told us from the schools component, but obviously we have other information as well from the case, and as I said, from the community. So we ask a lot of questions to different people in different places, and we use all of the information obtained from these settings to inform the determination of who is a close contact. Next slide, please. So, as I said, the close contacts are identified based on the information that we've gathered through the public health risk assessment. And they may well have different number of contacts identified, for example, in 2 cases in different classes, and that's because the information that we get changes. And I appreciate that can be very hard to understand, that although we have a very systematic approach in terms of the public health risk assessment undertaken and how we apply that in a clear definition of a close contact, that systematic approach doesn't always mean that the outcomes are the same or comparable. And when I started some of the schools work back in August, I was always very clear to say right at the start that comparing therefore between classes, between schools, will not yield any satisfaction, because it will not seem like there is a clear pattern. And that's because, as I said, we get information from 3 different sources, and therefore how we need to use that to apply that will be different. For example, in your 2 classes, you could have somebody who was there very symptomatic for a longer period of time, another person in a different class who wasn't there whilst they were symptomatic at all, or they were there and asymptomatic when they were there. So that would have a different impact. So it's just to give an example, because I understand from our communications with you and other communications that does seem odd and does seem strange. So it's just to try and put a little bit of context and explanation around that. So there is a very systematic approach, but it doesn't yield a consistent outcome. And that's usually clinically very appropriate. Next slide. So in terms of what the close contact definition is that we use in the educational setting, I've copied this from the Health Protection Surveillance Centre website, and at the end I've got a slide which links to the HPSC website, which has the documentation on, so you can read more at leisure and you can go back to it. But in essence, for a facility where we undertake a public health risk assessment, and that includes schools but isn't exclusive to schools, we are looking at any person who's had face-to-face contact for less than 1 metre with a confirmed case of COVID-19 for over 15 minutes in a school day, and any person who has been between 1 and 2 metres from a confirmed case for over 15 minutes, with consideration of the other mitigation measures in place. And those mitigation measures have been recommended and they were outlined in the roadmap for opening the schools, and you've all been working extraordinarily hard to implement those and to consistently implement those. And really we've had some, from my colleagues around the country, a really lovely feedback of how well you have done with that. So you and your colleagues and everyone in the school setting are really much to be congratulated for that. So, you know, those mitigation measures are really important. There are some areas in some contexts where obviously that is more difficult for people to implement, and that influences the public health risk assessment, for example. Next slide, please. So as I'm sure you know, with any close contact, we ask that that person be excluded, and they're asked to restrict their movements. And that's the same for any person nationally, and it's the same recommendations. They are asked to restrict their movements for 14 days, and that really means staying at home within the household setting, not attending school or any other group activities, and not travelling elsewhere. They are then referred through the HSE system for testing, and the usual testing practice is to have 2 tests, one as soon as possible and one 7 days apart. Day 0 and day 7 they are determined, but sometimes, depending on the time frames when someone might have been symptomatic and saw their GP and the test results come through, sometimes it's the timelines align such that only 1 test is recommended, and that's really on sort of public health recommendation, depending on the time frames involved and the impact that we think it has. So usually it's 2 tests, but sometimes it will be 1 test. And for the schools process, we've developed a bespoke testing process where the prioritization occurs of all of those tests for the close contacts that go through for the school setting. And that's coordinated through a school's testing pathway, and it's for all staff and all students. And I'll talk a little bit more of that as we go through. Next slide, please. So this slide is a busy slide, and it's not really that you would understand the detail. It's more just that you understand there is quite a complex process within the HSE, within the Departments of Public Health, to make sure that all the links are correctly made, and that we can get the tests referred to people, that we can understand who they are as a group, and that we can get those results back as a group. And that's quite complicated for the number of settings that are required. As you know, there's a lot of schools out there, and a lot of schools have been referred into us because of cases of COVID-19 for risk assessments. So keeping a handle on that is no insignificant task, and there have been many people that we've redeployed in to help us and facilitate that, and to keep that as sharp and as timely as possible. So, you know, the process kicks off really with someone being notified to us, and that goes through the normal HSE processes where cases are rung and the contact management program starts, and then they identify someone within a school facility, and that's when it comes through to us and we start the process. And the testing that is required or determined to be required by public health goes through this bulk testing process. Next slide, please. And one of the really important things for us about that is that we get batched resulting. I suppose there's 2 things that are important about having the prioritised testing and people not, for example, going off to their GPs to have a test done, is the fact that when the tests are taken, they are stickered such that they are a priority when they get to the lab. So they get run as a priority, so we get those results and that turnaround as quickly as possible. But also equally important from a public health doctor perspective is the fact that I get all of those results together. And this really is important for us to make an effective, speedy determination of what might need to happen next. And that's because each individual result is important to the individual, but everyone's result is important to us to know what to do within the school setting or any other congregate setting. So it's really important that we can see all of those results together. So if they batch together, if they go through together and they go through to the lab together, they come back as a batch of results. And that really makes it easier for us to look at all the results in one go, know that they apply all to one class or one pod or however it was determined, the close contacts. And then we can look at that and get more information as required and determine whether we need to make wider exclusions and undertake further testing. So that's really helpful to us. Whereas if they go off and all get tested by their own GPs, you're trying to match people back together. Were they in this school? Were they in that class? And that makes us making decisions for a school, from a school perspective, more difficult. So this process is really helpful for that, and that's hence we encourage it to be utilised. And also through the whole process, we might learn of things that we can do to support you further in terms of mitigation measures and resilience, particularly with the number of close contacts identified. And that can be important and useful and helpful to some of you and to some of your colleagues. So if we spot things that we think could be helpful, then obviously we discuss those further with you. Next slide, please. So in terms of the information resources available to you, hopefully you're aware of most of them out there. So there is information, the FAQs for schools that are available and up on the HPSC website and the Department for Education website. If you go on again, I think there's a couple more coming in. So there's a parent's guide to the close contacts, which was written specifically, I suppose, with parents in mind from with a child, that when they get a telephone call to say that their child has been identified as close contact, to give them that information and that they require. And if you click again, yeah, apologies, there's I was requested to do some little short video clips, and they're also available, that going through close contacts and what COVID-19 in a school setting would mean. So there's 2 or 3 videos, and I think they're all linked on the gov.ie website. But apologies, I'm no media girl, I went through medical school instead. So moving quickly on, the only thing that I will say about that is we are also getting translations. They are currently obviously in English, but we are getting translations for some of the information, particularly the close contacts, in a selection of languages to make that more accessible to some of the communities in place. So they are in train and will be available hopefully soon. In terms of the school teams, I'm sure you would have heard a good bit about school teams. Well, in essence, they've been in place from the start. Within the Departments of Public Health, we identified people who would work predominantly within the school setting, and that's because, you know, we have a whole array of cases and places coming into us, as I'm sure you appreciate, in terms of nursing homes, residential care facilities, other workplace settings, hospitals, etc. So there were people who are identified predominantly to work within the schools area, but obviously we must all cover from a medical perspective, and so there is some coming and going within the teams as they stand from my level of input. As I'm sure you're aware, we were severely challenged with significant increase in cases in October, and that was across the board and affected everywhere, affected everyone. And of course, it had a massive effect on departments of public health and on the contact management programme, who would need to contact the cases. And that ability to contact the cases and to find out who they were, where they were, and were they in a school setting became a longer time frame, and that meant the time frame coming to ourselves was longer. And then we had a huge amount of work because of the increased cases, which meant our timeline coming back to you increased as well. So it all happened the wrong way, that you had more difficult access to public health, and the response times from public health increased, and it was challenging and stressful time, particularly for yourselves and particularly for my colleagues working within the public health departments. If we go to the next slide. So the school teams have been, I suppose, significantly supported to make them more resilient and make them more focused for the school's work that we're involved in. So there have been redeployments again through the HSE, and that has been common throughout the whole pandemic, really, because we've all had to respond to need when and where it has arisen. As you know, the HSE Principals Line has been started, and I think has worked well from our perspective in terms of having a central place where calls come into, and then they know how to reach the correct Department of Public Health for us to be able to follow up directly with yourselves. We've had specific schools coordinators that we've brought into the department, specific people for the role of coordinating all the different elements of school work, because there's plenty of queries that come in. There are plenty of schools that come in requiring risk assessments. We then have to do the follow-up in terms of the testing and the resulting. And so each school is live with us often for quite a while. So there's a lot of work required in that coordination. So making sure we have enough people and the right people to do that is important too. So it's great that we have someone with that focus in mind as well. As I'm sure you're aware, we've been also supported by the Department for Education Inspectorate and DCYA, the Better Start Early Years Specialists, and they've come into our teams and have been a huge asset, really. Obviously, health has been very new to them, but education is second nature to them. So it has been, I think we've taught them obviously a lot from the health perspective in a short period of time, but they've also taught us a lot from the education perspective in a short period of time. So I think that is very helpful union, and it's certainly working well within our departments, and that resilience and that strength and the fact that they are used to schools and used to talking to yourselves, I think is very helpful. And having people who are specifically engaged for the schools is very helpful. They're not going to get pulled into issues with nursing homes, for example, whereby other clinical team members might get pulled hither and thither a little bit depending on clinical priorities. So it also helps keep that focus and keep that resilience for the school's response. And so that is only a few weeks in, and obviously there is a significant amount of training that is required for them to want to take the new work, and many of them are working away very well within the teams now and hopefully enjoying that. So that will stay and that will continue for the foreseeable future, which is good news from our perspective, and hopefully will increase that accessibility and resilience from your perspective. And the whole idea is really that we can provide an enhanced and speedier service for yourselves and for the children who are affected as part of this. Next slide, please. So I just wanted to run through a few clinical points, and many of these, you might be very familiar with, and some maybe not. So apologies if they are familiar to you, but they're the kind of questions that sort of come up a good bit, so I think it's worth just highlighting. Children are generally more likely to have a mild disease. That's something that we've learned over time with COVID-19, where when we started back at the start of the year, there were a lot of unknowns about how much children were affected and whether or not they were the drivers of infection of COVID-19. Because often children are thought of as a driver of certain other infections, but the evidence has really shown internationally that in terms of COVID-19 infection, children are really not the drivers of infection. So those two things were very reassuring in terms of considering schools opening up again. I think it's really important to keep re-emphasizing that no one with symptoms consistent with COVID-19 should be attending a school without having discussed first with their GP. And I know a lot of you are going to great lengths to make sure that that is implemented within your school setting, and I commend you for that. And it's absolutely a priority that you do that. If any staff or students come in or think that have a suspicion that that they're not feeling well, we'd much rather they stay out and see what happens with them from a symptoms perspective and discuss with their GPs if need be and get tested. So I know that's an approach that a lot of you have been taking, and I think that's correct. So we don't want people in schools with symptoms which could be consistent of COVID-19, and you will have your isolation guidance of what to do if you have someone who you suspect is unwell and could have symptoms, how to manage that within the school settings. And that component is really important. And that's because, if no one is in the school where they are very symptomatic with COVID-19, that's one of your best protections for onward spread. So when we are notified of a confirmed case, that individual is already out of the school environment. So when you hear of that, that individual should not be within the school environment and is likely not to have been there for a day or so at least before they get the result. And were they to have spread infection though, the incubation period for another person to get the infection is up to 2 weeks. The average is 4 to 7 days, but it's up to 2 weeks. And that's really important because I think people worry that if someone was there and there's a confirmed case, that in the day or 2 days where that's being determined, that the onward spread has been spreading and spreading and spreading at a very fast rate. But the incubation period, it's up to 2 weeks and the average is 4 to 7 days. And so that does provide some time. It's very anxiety provoking, but from a clinical perspective, it does provide a window of time, which is very helpful. So with the mitigation measures implemented and in place, you know, it maximally helps prevent the onward spread of disease, that we're doing everything to make sure people aren't there when they're infectious, that all the right things are being done to minimize the spread in terms of respiratory etiquette and hand hygiene and cleaning, and the fact that it takes 4 to 7 days, but up to 14 days for that spread to be realized in another person. Next slide, please. So in terms of some of the data, I thought it might be interesting to just look through a little bit of that we've identified. So this is data that we have from the school's bulk testing process. So when we're notified of the case, you then get we then do our risk assessments and identify close contacts, and then we look at the testing and the testing positivity of the close contacts. So this is what this data pertains to, and this is really recent data. You're the first people seeing it. It's up until the 30th of November. So far we've been involved in 833 educational facilities where we've needed to undertake public health risk assessments and organise onward testing. And we've tested as part of that 23,346 people, staff and students combined. And we found 538 have tested positive for COVID-19, which gives an overall testing and detection rate of 2.3%. And you can see above the area that might be most of interest for you, and that's average is 2.4% within the primary setting, 1.9% within the post-primary setting, and 3.4% within the special educational needs setting. So that detection rate of between 2 and 3 per 100 people testing positive amongst the close contacts that we have identified is relatively low compared with the community testing. So if you're identified as a close contact within your community setting, you have a 10% chance, a 10 in 100 risk of testing positive for COVID-19, whereas it's between 2 and 3 if you're a close contact within a school setting. So that's reassuring for us too, and it supports the evidence beforehand that children weren't the drivers of infection and schools wasn't an amplification setting. So the data that we've determined up until November from when schools opened do support those international findings. In terms of the breakdown of close contacts between students and staff, it's roughly 86% have been students and roughly 14% have been staff, and the positivity rate's been very equivalent amongst them all. Next slide, please. And if we just look at the last week, so this data is just looking at the last week, we have been across the 8 departments involved with 115 settings, testing just over 2,000 individuals and identified 38 further cases of COVID-19, giving a detection rate of 1.7%. So again, still maintaining that lower close contact positivity, which is good. Next slide, please. So that data is now available for you, and this is the website link for you, and that's up on the HSE website. So you're able to look at that as a weekly report, which will give you cumulative data and weekly data. So if that's of interest to you, then that's something you'll be able to look at. Next slide, please. So we also decided to want to take a review of the first half of the term to really kind of tease out a few more elements of the cases and the settings that we were finding. And when we looked overall at all the proportion of all cases of COVID-19, and the proportion who are children who are identified as cases of COVID-19 remained relatively stable since the opening of schools. So from August to October, that proportion was roughly about 14.5% up to 15% throughout the time period before school and after school, which again, despite all of that mixing, is reassuring that the schools aren't acting as an amplification setting as a general rule. We had detailed data available for 7 of the 8 regions served by the Departments of Public Health. And in approximately 70 instances, we identified where some spread of infection was deemed plausible or likely to have occurred. And that was up until the first half of the term, up until Friday, the 23rd of October for the data that we had. We are sort of, we include as much as possible, if that makes sense. So where we're concerned that it's quite possible that, or it's plausible that this case could have gotten their infection from within the school setting, we'd include it. We'd rather be pessimists, I suppose, is our approach, to make sure that we're keeping as close an eye as we can. It is very difficult to say definitively where someone got their COVID-19, particularly when rates are very high within the community, as they were in October time, because by and large, a lot of what we were seeing in the schools was reflecting what was happening in the community. So if you would test people, you would identify positive cases, but when you looked at the family, they might have had parents who were symptomatic a few days before, or were already determined as close contacts from a different setting. So we've identified them within the school's testing, but it doesn't appear likely that they were necessarily infected through the school setting. And, you know, that's a little bit of detective work, and it works on knowing new communities and knowing symptom onset dates, etc., etc. But as I say, we take a pessimistic approach, and if we think it was plausible or likely to have occurred within a school setting, then we looked at it and kept that in. Next slide, please. So if we modelled that across the 8 departments, because one department we didn't have that data for, approximately 1.9% of primary, post-primary and special educational needs schools had any plausible or likely transmission of COVID-19 within the facilities. So that was 12.5% of the facilities that we were involved with in terms of investigation and testing. And that spread involved 194 staff and students, 24 clearly designated as staff. And so in terms of the proportion of people that accounts for, it's 0.02% of all staff and students within the school settings. And when we think spread did occur, approximately 3 other kind of cases were identified as part of that. Next slide, please. So in terms of our other findings that we have national discussions regularly with the team members across the different departments, whereby we discuss issues that come up, we discuss maybe difficult cases or difficult scenarios, and we discuss some of the themes that we're finding. And many of those things are things that we then discussed with Deirdre, and we've worked on how we can maybe support or highlight. And I suppose one of the clear areas that became noticeable for ourselves and is a feature not just within the school settings that we're quite familiar with in terms of residential care facilities and other workplace settings, is the controlled space is generally very well controlled. And so the classroom, in the class teaching time, there are good processes in place, and people are generally very disciplined and implementing all the measures. And then, you know, we're all human beings. We have that few minutes where we rest up and we let up. We have break times, and a lot of that is really important in terms of interactions between children and interactions with colleagues. But friendship groups and break times is often an area where we might identify more close contacts, because one, people have to eat, so you know, face coverings will be removed for that if people are wearing them, but we relax a little bit more and maybe don't implement all the measures perhaps as strictly as we could do. So, you know, that's an important thing for us to note, and I think for a lot of schools have taken on board in terms of how they look at that and how that can be considered. And I've highlighted the staff rooms there as a specific issue, and you know, we've seen different models implemented in all the schools that we've looked at. Some people have sort of a very rigorous approach in terms of timings when people are allowed to be in the designated seating, making sure all the seats are fixed and they are far enough apart, etc., and the ventilation, and others where maybe there is less coordination of that, and sometimes people sit as groups of people, and we've noted that sometimes that can be within certain subject areas, and then if you identify those as close contacts, that can have a big impact on the school in terms of losing a clutch of a certain type of teacher, for example. So those are findings that we've tried to share amongst ourselves to feed back to schools and with the Department for Education, just to think maximally how you can implement the measures to protect onward spread in all circumstances, I suppose, and how to mitigate against the number of close contacts that might be identified and the impact that might have from a staffing perspective, particularly on the school. There's also obviously travelling into and out of school, buses, cars, car sharing, etc. And that's an area that we consider as part of our public health risk assessment. And it's another important area to encourage, it's outside of your domain, but I suppose as part of the broader school community, to encourage that that transportation is done as per best recommendations, public health recommendations, to make sure that minimum contacts and onward spread can be identified through that setting too. And this report is available also on the gov.ie website, so it's another one that you can look at and read for, yourselves at more leisure. So I just wanted to highlight the resources. You may well be aware of all of them, but there are significant resources on the gov.ie website. There are significant resources on the hpfc.ie website with regards to the educational guidance, and the HSE link also has some resources, and that's where the data and some of the videos are held too. And that's me. I think that's my last slide. Thanks very much.
Okay, thank you very, very much, Abby. And I know that you provided an awful lot of information there, and I'm sure everybody's found that very valuable. And just to mention a couple of things, the webinar is being recorded, so the information, the session can be looked at again, or it can be accessed by people who weren't able to attend this evening. And just to say also, we've got quite a lot of questions into the chat group, so we'll try and get through as many of them as we can, but we will gather all the questions that have been posted there, and we will add the answers to the FAQs for principals. So I might just start off with some of the questions then, try and get you through as many as we can. Just to mention, actually, someone has asked about the phone line for principals. This is a specific number that has been put in place for principals to access. It's a 7-day-a-week number, and it's a direct line to public health. And it really is in the context of where a principal is notified of a confirmed case in their school and they want to talk to public health and they're waiting a call from public health. In most circumstances, public health will get in touch, but if the principal has concerns in the interim. And that might just bring me nicely to one of the other questions is, can we explain the delay or gap between a person gets notified of a positive test result, like a parent knows their child is positive or a staff member is positive, and a principal is still waiting for a call from public health? So
well, Deirdre, it's Kevin.
Give Abby a break.
It's Kevin, yeah. Just to say, on the whole, when that happens, the principal is being told really very quickly by the parent or the teacher because they've received their text. So that's almost instant. They get that as soon as the result is known. So that's instant, okay? It takes another number of hours, 4 or 5 hours, for that then to percolate through to the public health department as a consequence, okay? And for them to pick it up and for them to take action on it as a consequence. So we are never going to be as fast as that process, because by the way we've set it up such that the results go out by text, we will never be as fast as that. And clearly people will then, generally speaking, take up and phone the school, either because they're a parent or because they're a teacher needing to speak to their principal as a consequence. So we will never be as quick as that, okay?
Great. So in that context, maybe we could you explain a little bit about the infectious period? So
well, Abby spoke about that in her slides, her presentation. As she said, technically it's for 14 days after the symptoms start. That's the full period, although we do know it is, generally speaking, people are most likely to be infectious after around a week's time. Okay, so it's been precautionary as a consequence, that 14 days, and we do still see some cases where the only link is as a consequence of them being in contact with somebody after they've had the disease for 10, 12 days. So it is at that nature, but on the whole, people are most infectious around the time of 4 to 6, 7 days, generally speaking.
Okay.
And I think, sorry, Deirdre, I was just going to come in, and that was just a point reinforcing that I was trying to make in the presentation, and that's what gives some time. So as Kevin said, because we give out the instant text response as soon as it comes in, it's an automated thing, which is absolutely the appropriate thing to do, but it has to come into the contact management program. We have to ring up the case to discuss all sorts of details with them and find out that they were in a school, and then when it's in a school, that comes through to the Department of Public Health such that we can investigate it further. So that's always going to take a period of time. But the important part is that in person with the COVID-19 is no longer within the setting. And as Kevin said, it is 4 to 7 days and up to 2 weeks before another person will develop those symptoms and be able to spread on. So there is a time lag and a time delay such that although it's very anxiety provoking, knowing that there may have been an incident within the school setting, we don't know still that they would have been there infectious, and you wouldn't necessarily know that yourselves as principals either. But there is a time window that is clinically safe, I suppose, for that to happen. And we understand the anxieties with that, but it's 4 to 7 days on an average time period before that next person would be infected and display symptoms. So it's not spreading under your nose, sort of, as you're going throughout the day, which I think can be a real sense of fear and anxiety.
Okay, and we have had some questions about whether or not there's any evidence about whether asymptomatic people are less likely to spread infection. Is there any evidence around that at the moment?
It's a mixture. It's a mixture of both. Yes, they are less likely, but then equally there have been instances where people who are asymptomatic have had quite a lot of spread. It's not, there's no certainty as of yet with this disease. I mean, in most diseases history, this is like still being in the first week of life almost. We're still learning a lot about this disease. So yes, it's the asymptomatic, I think, is one of the troublesome bits of this, because it isn't asymptomatic and i.e. not being passed on. There is still an element, a reasonably good element of it being passed on while people are asymptomatic. And so there is still some concern about that. And that is a difficulty we have to face into with how we deal with this disease as a consequence.
Okay. So we've had some questions, a range of questions around close contacts and identification. And I know Abby covered it very well in her presentation, but maybe just to summarize why close contacts are different in a school setting.
I suppose the core component of that is because we look at 3 different elements. We look at the school setting, we look at the case, we interview the case, and we know our communities. So there might be outbreaks in certain contexts and certain other workplace settings that parents might work out. So it's a combination of 3 bits of information that we use to determine who is a close contact. So as I was sort of saying in my example, you could have 2 children who might be siblings and in a school and in different classes. And one class we might ask for everyone to be excluded, and in one class there might be hardly any close contacts. And I absolutely get that might seem odd on the outside, but someone might not have been there. One of the children might have only been there an hour in their infectious time period versus one of the other siblings who might have been there 2 days. And one of them might have more behavioural difficulties, so therefore they're less good at complying with the mitigation measures in place, or requires more close one-on-one resource teacher care, for example. So there are a lot of different circumstances. Each school is individual, each class is individual, each person is individual, and each community is individual as well. And it's that blend of information that determines the close contact. So, we have a very systematic approach to how we apply it, but that doesn't mean that you get the same outcome.
Okay.
I don't know if Kevin can explain it better.
Yeah, well, I think the other thing we have to be clear about, and we've, Deirdre, we've said this on a number of occasions in some of the other meetings we've had, is that we have guidance about how we do things, and there's guidance for schools how they do things. And if we all did those exactly perfectly, things would be very simple to explain. But that doesn't happen in either instances because things are different. Each school is different from the next door school. They may be following the guidance fairly well, each of them, but there's just different ways of how they work as a consequence. The classrooms are different sizes, they've got different circumstances. So you have to take all those things into account. So that is what we're doing, that's why people say, well, it wasn't like that in the school across the road or in my own kids' school as opposed to the school I teach in, because schools are different. And you have to take that into account as a consequence, which I think everybody would want us to do because schools are different and unique in that sense.
Okay, and maybe briefly just to cover off the role that the COVID app might play in the context of a school setting, because I know that has caused a little bit of confusion in certain instances.
So sorry, did you want to come in, Kevin?
No, because you're the expert on the app.
We should hold up a little card as to who yes. will answer first. So I'll start, and you can finish if I've left anything out. So the app informs the public health risk assessment, and what's important to note is that the app is a piece of technology, which means it's very accurate at some things, but it can't take account of lots of things. So it is very accurate at measuring phone to phone, the distance and the time period that those phones were close together. But of course, those phones might not necessarily be on the person the entire time. And also it takes no account for doors, ceilings, walls, perspex screens, face coverings, hand washing, etc. So, what when the app goes off it's usually for a staff member is the experience that we have with it. It may be that when we use that information, but we get a lot more information from the risk assessment about what has been happening in the school. And if you determine that actually with all the mitigation measures in place, or someone left their phone somewhere else, or actually there was perspex screens between the teacher and the other person, then it's the public health risk assessment that determines who is the close contact. And because it's an automated process through the HSE, that is always going to trigger an alert when the 2 meters is reached. So an information piece has gone out with that, such that people working in any congregate setting, not just schools, it happens in all sorts of other congregate settings, are aware that if a public health risk assessment is undertaken, it may determine differently whether you are a close contact or not. But we appreciate it's slightly a confusing space, but it's that blend of using technology to support versus having people to actually get to identify a lot of the information that's richer and more important in the context of the spread of COVID-19.
Okay, that's great. And this is another one that's closely related to the close contacts situation. And it's to explain why pupils or staff members who have a household member who is a close contact, why the other people in the household don't have to restrict their movements pending the household member's test. So pending the test of the close contact.
In our guidance to date, we have not got to the point where we're saying a contact of a contact has to take actions at the moment, okay? So therefore, if you are a contact of a contact, you are still able to go about your business, generally speaking. I think it does bear in mind about how that actually happens in households and things of that nature, but on the whole, we are still saying if you're a contact of a contact, that contact gets their results or whatever, then you don't need to isolate yourself at that point in time. It's it's just that's part of the guidance. It can change, it may change, it might not change, but that is what the guidance is at the moment.
Okay, great. I might move on to another theme now. Just to cover off something that's come up around travel advice. I think we have government travel advice, and we would be recommending for all schools and all members of the school community to follow the general travel advice. So if people are traveling abroad for Christmas, they must follow the government guidelines and isolate on their return. So I don't know if Abby or Kevin want to say anything specifically about the travel advice. Just to mention, there was some confusion that under sixes wouldn't have to restrict their movements after returning from abroad, but that is no longer part of the advice, and the under sixes are required to restrict their movements just like everybody else.
It's very clear from a public health point of view that we believe that it's best if people returning from abroad restrict their movements for 14 days. From our perspective, that's the best way to try and keep the disease in control as much as possible. And that clearly is our advice as a consequence.
Okay, so there's been a couple of questions around face coverings, and maybe the first one is about face coverings or visors, and what's the recommendation?
We've moved away increasingly from visors, except in those very few occasions where it is clearly not an ability for the individual to wear a mask, and then a visor may well be appropriate. The visors are even less well used than masks on the whole, and so we would prefer that wherever possible should be a mask should be used in the circumstances. Okay, but we're not saying that's an absolute, but on as much as possible we would expect the mask to be used. Clearly in some of the circumstances, and particularly in some of the circumstances around kids with special needs, and some of those circumstances, it may be that you can't use the mask, but but on the whole it should be. And so you should hardly see a mask in a school, a visor in a school, unless there are kids with special needs. I would have thought it is very uncommon that people shouldn't need. Okay.
Okay, there are also some questions about students removing face coverings to eat. And is there any specific?
Well, if you can tell me on this call, there's anybody who can inform me how you can eat and keep your mask on, I'd be very impressed. I have seen somebody managing to smoke and keep their mask on, but that was because they poked a hole through their mask and were smoking through the mask. But, of course they need to remove their mask for eating, and that should be done. And on the whole, if they can do that in the groups only that they are in normally during class time, that makes it a better thing. And of course, they should put the mask back on as soon as it's practical as a consequence. Okay.
Okay, so is there currently any guidance about students wearing masks outdoors? So if they're outside?
Well, the guidance has changed in the fact that it's been considered that if it's considered a busy, and that's a difficult word to define, but I mean busy area, you'd expect them to be wearing. But that's in a sense, and I can't imagine many 5-year-olds, 6-year-olds being static long enough for it to be an issue when I see them in playgrounds and when I watched my kids of that age many moons ago. But for others, maybe. And then if they are congregating outside in smaller groups, then maybe they should be wearing the masks as a consequence. And that's what it's about. It's very clearly that we're saying you need to wear masks in, like shopping malls, but it's equally, you can imagine as we move up to Christmas, that places like Grafton Street, or I live in Limerick, O'Connell Street or William Street may well become really quite busy. And therefore maybe it's appropriate. And maybe that's the same in playgrounds and in the grounds of schools where people are congregating, and, I won't talk about schools, but I live in Limerick, as clearly there's a place here where a lot of teenagers go, and they clearly are grouped together in a way I would expect they should be wearing masks at that time, as opposed to not wearing masks, because they're very clearly close together. But that's an issue about how the school needs to manage the situation, and the schools have much more knowledge of that than either Abby or I would ever have.
Okay. So
and clearly that's an issue mainly for secondary schools as opposed to primary national schools.
Yes, at the moment the guidance doesn't cover primary children.
No, and that's not changed.
Exactly, that remains. And I just feel the need to clarify that we don't advocate smoking, or particularly smoking with a mask
No.
on.
Right.
It's
And
one
that
of
was
those,
on
do
the
not
street.
try this
That was
at
on the
home.
street by an adult. Okay.
Okay, so we've
Can I
had
just add, there's just a question on the thing. Travel to Northern Ireland at the moment is allowable because it's part of the Irish economy, a very integral part of the Irish economy, particularly at the borders, both in the education system and for us as well. Okay. They are, it's a key issue for us that we have people moving across the border to work. So yes, Northern Ireland is there. But like all these things, what we're trying to do is to reduce social contacts, even going into Christmas and around Christmas, to try and reduce the transmission of the disease. So the real issue is about reducing social contact and reducing the transmission of the disease.
Okay, we've had some questions about ventilation and guidelines on ventilation, and particularly in the context of the onset of more wintry weather. And just to let everybody know, the department has provided updated guidance for ventilations in schools, and that's gone out to all schools, and it's on the gov.ie website as well, in the context of updated guidance around ventilation. So that is available. Just a couple of more questions that are around. One is around serial testing. Why don't we do serial testing in schools?
Because we believe we have got a system in place now that is actively managing what's happening in the schools very well, both with the advice that is being primarily followed and what's going on. And also you're talking in where we've been at, you were talking about very different arenas. If I just take the meat industry, let alone going into nursing homes, in the meat industry, the issue was the fact that people were standing virtually cheek to jowl in a very high intensity activities, high level of spray of stuff around it, a lot of stuff going on. So it was very, very thick. They've changed dramatically. And the reality is we could probably, if we wanted, or if there was really had to do so, stop the screening, the serial testing in the meats industry. Nursing homes and healthcare facilities are very, very different facilities with a very different population. This is a disease that is very, very age related. For most of you, you can see me, I'm at just at the bottom end of the group that are starting to see their risk change dramatically as you get older. Within 15 months, if we don't have any other major changes with vaccines and stuff, my risk goes up nearly tenfold because I move into the over 65. It's a massive difference. It is so there's a big difference between what we're talking about in these circumstances.
I think just the other thing to reassure about is, we've looked at over 20,000, we've tested over 20,000 people as close contacts. So, at the highest determined risk from a case that we know is a confirmed case. And the test positivity has been around between 2 and 3 in 100. And so I think that is really reassuring, where we know there's been an active case, where we know that there's been really close contact, that only 2 or 3 in every 100 have tested positive in that setting. And I suppose the other thing just to bear in mind is that, especially children being tested for COVID-19 isn't particularly pleasant. And actually you see that a lot of people don't routinely after a while want to have the testing done. And one concern of ours in public health is that when you actually really want someone to get tested for an active situation, they might not wish to do so because they've been tested a few times and they found it particularly difficult and intolerable for them to do that at a time when it was much less required. So it's a constant balance, and it's something that we'll constantly keep evaluating. We look at all of the data in all the different settings, and should there be a determined need because something significant changes, then it's not something that's not considered, but at this point in time it's not something where there is evidence to support that it's necessary or desirable.
Okay, we have a couple of questions about somebody who gets a negative test result and when they can come back to school. So maybe if you could outline
It
this.
depends on the circumstances to a degree, but normally speaking, you would expect them, the negative test, to be linked to, if they had it because they had symptoms, then you'd expect them to be able to return to school when they've not had symptoms for 48 hours, or if they are as a contact, they have to maintain the 14 days as a contact, because the test doesn't do that. A test only says you're negative at the moment the swab was in your nose. It doesn't say you're negative the next day. So, or the, so that's the important issue. So doing that is, the test is helps, but it's not, but it does depend upon the actual circumstances. So if you're a contact, it still means you have to maintain the rest of the period, no matter when you have it, be it the day after or at 7 days.
So the difference really applies whether if somebody has symptoms and they go for a test and that's negative, it's a different
rule. They have to make sure the symptoms have gone and 48 hours, Abby, before Abby's disappeared, before they are able to come back.
Okay, there's a couple of questions.
Sorry, Deirdre, Abby's gone, so it's just me at the moment.
Okay, not to worry.
You can say that.
We're running over time anyway, so I'm just going to probably finish up with one or two questions around school staff and using the staff rooms and whether or not staff should wear masks.
Okay.
Outside of the classroom setting, like in the corridors.
As Abby put in her slides, this is something that is very clear, both from the education arena and also from the healthcare system, that restrooms, staff rooms, whatever phrase you want to use, where people aggregate together, are problematic. The office or something like that. And we've noticed that, and it is very, very hard for staff to maintain for the whole of their time, be it the 6, 8, 10 hours that they're in a school, the 10, 12 hours they're in a hospital, to maintain that observation the whole time through. And it is clear that that does sometimes slip, particularly when they're resting, as you would expect. So it is important that people try to maintain what's happening during in the staff room as much as possible. So they observe the 2 meters, they observe having the masks on when they're not eating and drinking, things of that nature, it's all possible. And equally, they don't congregate together in offices or things of that nature. I'm not sure that we've observed that as much in schools, but that clearly has been an issue for us in the healthcare system.
Okay, thanks, Kevin.
There's a bit about singing on the thing, Deirdre. Singing is a problem. The national, international evidence shows that singing has been shown to be one of those events that does spread the disease quite well. And as you might expect, because of the very nature of the loud expansion of your lungs, I can always remember being told to move on, make it louder and things. So it is a difficult thing, and particularly in a confined space. And it is probable that if it's all possible, that singing, choral practice at this time should not really be happening. I don't think it's as big an issue necessarily for individuals who are doing their singing as part of their post-primary courses, but I think choirs and things like that are problematic, unfortunately.
And unfortunately, the recommendations won't be that. Sorry, I've had to turn my camera off due to the vagaries of technology. But in terms of, I suppose, the festivities and Christmas plays, that's singing inside and Christmas carol singing is not something that would be recommended at all.
And somebody has asked about how about some carol singing outside. I just know that it is a particular issue this time of year for schools, so it's
but I mean, I think it's difficult because you have to still make sure they're 2-3 meters apart. It is problematic. Let's just say it's one of those things that are going to be difficult, and I wouldn't be advising it. And if my kids were around at that age, I'd be telling them not to be party to it this year.
Okay.
And that aligns with the recommendations that are likely to go out in terms of, you know, churches and other places, even if they're bigger and well ventilated, that the recommendation is still will be not to sing and not to use woodwind instruments.
And it's interesting, my son is a pastor in a church in Scotland. They've got round it by actually recording the choir of 5 or 6 people in their own homes and putting it together and using the music separately on the in the church services. There are ways around it, but you know, I think that the activities we normally associate with Christmas are not going to be easily done this time round.
Okay, there are some questions in general on other guidance around practical subjects and PE and toys. And just to say that we do have a lot of this information already on the gov.ie/back to school website, and we will link that again for schools. We try and send out a link via the OCLS system, which Kevin and Abby won't be familiar with, but every principal and deputy principal on the call will understand what I mean. So we will send that link out again, just emphasizing where that guidance is. And there is quite a lot of guidance around those operating those subjects in the context of COVID, and a lot of practical guidance and support there.
Deirdre, can I just add something at the very end now? I think one of the things, it goes back to almost the first slide that Abby showed, and it is a total tenet of hers and my practice as doctors, is about prevention. And in these circumstances, the reality is prevention is better than cure. And so it really is that everybody carries on with doing what they've been doing, trying to get these rules in place, trying to get the observation of the rules and things of that nature. And some of the very basic ones are trying to ensure that people don't come into school when they're symptomatic. Be they know they're symptomatic and are still coming in, or coming in when they're hoping they're not symptomatic when they really are. And if they've been told they shouldn't come in and they come in, that's even worse. But you know, that's part of life. So it's a real issue. So it is that preparation. And the reality is, you know, after, you know, I would say, if at all possible, and I know schools and the principals will be doing it, is they use what they've learned this term to look back and say, how can we improve for next term to make it better? And we will be there to support you. And as you know, Deirdre, we'll respond to questions as quickly as possible, okay? And we'll respond to the ones here and point people to where they are and things like that. But it is a big issue that preparation and prevention are the best ways of dealing with this.
And maybe just to recap on a positive note, in line with the conclusion of the webinar this evening, Abby, I think you had quite positive statistics in terms of the positive cases from schools over that first term, and all we've learned, how well schools are doing. So maybe it's important to emphasize that as part of the conclusion of this webinar this evening. As Kevin has said and Abby has said, we will answer all the questions that we can and add them to the FAQs and send out links to all schools. Just to also maybe mention on a positive note, the department will be issuing the next round of COVID funding to schools, and we'll be issuing an update on when to expect that funding in the next couple of days. We hope to get that out with details of the next tranche of COVID support payments, which are helping schools to implement the public health guidance. I don't know if Abby and Kevin want to say anything just to finish up.
Not really. I think you've said it all. You said it all nicely. But I suppose to thank people for dialing in to engage, and we're happy to hear feedback of what themes are important to you that we can help you address. And I suppose just to congratulate you on, I suppose, the hard work and efforts that have been put in. And I think the data shows that that has been really successful. But that unfortunately there's no let up. So please continue, and please encourage everyone amongst the school community to abide and implement the measures measures, both within the staff, the students, and the broader community, because you know it's never nice when it hits home, and it's a very anxiety provoking time for everyone. And we are here to support, and support as well, and as deeply and as fast as we can. But I'm sure you'd rather not hear from us.
Okay, and just to say thank you very much to Dr. Abby Collins and Dr. Kevin Gallagher, who are very, very, very busy public health doctors, who are also working extremely hard to support schools. And on behalf of the department, we really appreciate all of the engagement, and thank you very much for facilitating the webinar tonight. We would like feedback, so there is a feedback forum at the end of the webinar as you're logging out. And I'd also like to thank IMS, who have supported the technology tonight, and the Education Support Network and Tralee Education Centre, who have worked, all of the Education Support Network have worked to support the putting on of this webinar this evening. So thanks very much to everybody, and in particular to the principals and deputy principals who have joined in this evening, and thank you all very much for attending and participating. Thank you all, and good evening.
Evening.